After assessment, what can be the goals of treatment? The goals can be the short-term goals. Everything and anything comes under short-term goals, guys. Your reduction of pain, your increase in muscle tone are all short-term goals. Being able to walk, being able to run are all short-term goals. Long-term goal is only a maintenance therapy. You can't include half of them in short-term, half of them in long-term. Running is not a long-term goal. Rather, walking for 2 kilometers is not a long-term goal. It is a short-term goal. But maintaining that is a long-term goal. Therefore, reducing muscle tone, breaking the synergy pattern, improving balance and gait, and treating apraxia, all of them are your short-term goals. The only long-term goal here we'll have is the bringing him or her to maximum functional independence and maintenance therapy. What are the phases? You have acute phase, rehab phase, and a maintenance phase. In the acute phase of PT management, first we should arrange the patient's room with main objects on the hemiplegic side, because either right side or left side, whichever side you notice the patient being affected, all the major objects in the room, people in the room should be facing that side, so that he has to or she has to move towards the affected side to see them or see the objects. Most of the places what happens is, if right side is hemiplegic side, all the objects, as we have already discussed, the objects are to be placed on the same side, that is on the hemiplegic side, but not on the good side. Most of the people in their house setups, what they do is, because they cannot reach with their hemiplegic side, they keep all the objects on the good side. Then what is the point? We have to target the hemiplegic side or the weaker side. That is when there will be neuroplasticity and the firing happening. If there are no new neural connections happening, then the brain will not have the need to even utilize that part of the body. Therefore, you have to counsel the patient's family members first, not to pamper them, one, two, to assist them, but not completely, making them a parasite. 9 out of 10 stroke patients, after their a little stage of recovery, become stagnant or plateaued because of this misarrangement from the patient's family. What they think is, it is not right to struggle the patient even more. He's already struggled or she's already struggled. Let's do something that we'll keep all the objects wherever he wants or she wants at their reach, so that it becomes easy for them, easy for us. That's not how it works. The next thing will be bed sore management. Bed sore management because of continuous sleeping position on the bed, there can be friction. Make sure that you tell the patient attenders how to manage a pressure sore or a bed sore using ice. Pillow placements, affected and unaffected side lying. I'll tell you, there's a next slide coming with diagrams with pillow places also, so that you will know how the limbs are to be kept in the side lying and also on the affected and unaffected sides. Bedside exercises can be done right from day one. Okay, so there is no myth that stroke people should not be touched for 2 weeks, 3 weeks. You have to give their own time to relax. Nothing like that. Once you say that the vitals are stable, start them with the exercises. And the bedside exercises include SLR, isometric quadriceps, and pelvic bridging. You have PNF, which works fantastic in them, like your hold, relax, contract, relax techniques work very, very well to start with. Also, once you see that the synergy pattern is breaking a little, you can start with D1, D2 patterns also. Chest clearance techniques, make sure that you encourage the person to do diaphragmatic breathing, and chest clearance have to be done. Huffing, coughing has to be practiced by the patient. Mat activities, yes. Other than the ICU setup, the inpatient setup or the outpatient setup will allow mat activities. Therefore, these are the set of mat activities that are very, very helpful and beneficial for the patients. That starts from log rolling, segmental rolling, supine to prone and quadruped, quadruped to kneel sitting to kneeling, kneeling to half kneeling to standing. This is the pillow placement that I've told you about, lying on the affected side, lying on the unaffected side. So if that's the affected side, the red portion marked one is the affected side, make sure that the upper limb is straight while the lower limb is bent at the knee. And if you're sleeping on the unaffected side, this has to be in extension. The affected leg has to be completely extension. Unaffected leg has to be completely in extension, while the affected side can be in flexion like this with a pillow support. Then comes the rehab phase or the subacute phase. Once you start with a vigorous therapy in the acute phase, you can continue the same while you can add exercises, because here the patient will be at the best of his or her cooperation with you, because they would have seen some amount of improvement. There is some back on track happening. Therefore, they listen to whatever you say. So, there can be an aggressive or a vigorous physiotherapy that can be done during the rehab phase. The subacute phase will exercises in lying will include SLR, pelvic bridging, and pelvic rolls, heel drags, active exercises for the unaffected side, while the exercises in sitting will include weight shifts, dynamic quads, resisted exercises for the unaffected side of upper limb and lower limb, unaffected side. And with the here we have exercises in sitting where weight shifts will include from left to right. This left to right weight shifting is very, very important because weight has to fall on both sides of the hips and the hip bones and the buttocks, and therefore that can improve the trunk dissociation. See, in stroke, what happens? Everything moves en masse. The hand, trunk, and the lower limb, all three of them are conjoined and they are together and they move like a mass, like a unit. But that's not the criteria. The criteria should be that there has to be a dissociation. This weight shifting will break the association and will make the dissociation happening when the patient is walking. This has to be independent, this has to be independent, legs have to be independent. In stroke, all of them walk in unison, like one unit that it happens. There's no arm swinging, there is no heel strike foot flat, there is no trunk control. This have to be encouraged and initiated through the exercises in lying and sitting. Dynamic quads, rested exercises for unaffected side of upper limb with Swiss ball. PNF techniques like your hold relax, contract relax, slow reversal help a lot in improving the proprioception and also the trunk balance. For spasticity, we have inhibitory techniques like your slow icing, sustained stretching, slow stroking, weight bearing, and joint compression. Some of the exercises have been mentioned here: pelvic bridging, SLR, dynamic quads, and human or have weight transmission through the affected side. So you have the weight transmissions on both the sides. This is what I encourage my patients to do, because that will cause joint compression, and this joint compression can reduce spasticity, can improve motor functioning or motor performance also. Exercises in standing can be mini squats, lunges, side walking, backward walking, spot marching, heel standing, and exercises with the Swiss ball. There are diagrams, that's why I'm not going much into detail about these exercises. These are the mini squats, these are the lunges, then you have sideways walking, like walking on the sideways, and then backward walking. Spot marching, you have a spot marching, just marching left, right, center, and then heel standing. These are some of the important exercises in standing that you're supposed to do. Along with this, on the Swiss ball, what you can do is bending with the Swiss ball, sleeping with it. When I mean pelvic bridging or a modified pelvic bridging, the Swiss ball and the will be your legs will be above the Swiss ball, and you will have to do a dynamic pelvic bridging or when your head is on the couch and the legs are on the Swiss ball, just like this diagram. You have your mini squats. You have your mini squats with the assistance of the Swiss ball, wherein around 5 to 10 degree mini squats are enough. And pushing the ball, because the push and pull activities or the bilateral hand activities are very important for breaking the synergy pattern on the affected side. Are these the only exercises left, madam? No, sir. There are multiple exercises. You can customize the exercise when you see the person. You know the patient very well. You know about their motor performance, their ability, their recovery rate, their age, their mortality, the morality, all of them matters. Depending on that, you can taper down or categorize or customize an exercise or design an exercise protocol. That's the beauty of exercise therapy. There is no hard and fast rule of performing only one set of exercise, but these exercises have to be done. After that, what is happening is the maintenance phase. The third phase is the maintenance phase, where you have exercises in standing where you continue them for a good amount of time. You can continue them for life, like your mini squats, lunges, side walking, backward walking, spot marching, heel standing, and exercises with the Swiss ball. All of them can be continued without any problem. Then comes functional training, with treatment for apraxia, agnosia, and ADL activity training. How do we treat agnosia? Repeatedly showing the same stimulus. How do we treat apraxia? You have different phases. So if there's a complete activity, break the activity into tasks, teach individual tasks, let him master or let her master all the individual tasks. Then you combine, let him master the entire activity. Then you put the same activity in different environments, which is called as, you must guess it by now, motor relearning program. Is this enough? Home exercise program is very, very, very important. HEP is one of the most important takeaway messages for every patient with stroke, not for just for stroke, for any condition. Home exercise program is extremely important.